What is it like for cancer patients living in poverty to obtain routine medical care? Poverty is associated with low education, inadequate social support and living conditions, employment, and risky behaviors. In 2014, the burden of cancer mortality surpassed that of heart disease in 22 states. The risk of African American women dying from breast cancer is 41% higher than white women throughout the U.S. Barriers found among African American women seeking treatment consisted of mistrust of doctors in the U.S. health system, feeling like they are being treated like a guinea pig, the Tuskegee syphilis study that negatively impacted African Americans, maltreatment by race, and concerns about the harmful effects of exposure to pollution and toxins in their foods, neighborhoods, and workplaces. These concerns are consistent with studies that have found higher levels of local air pollutants and environmental toxins in low-income African American and Latino neighborhoods. The National Cancer Institute concluded that poor individuals, regardless of race and ethnicity, are diagnosed with more advanced cancer and have lower rates of survival rates than those living in more affluent communities. A qualitative study reflected experiences of the urban poor with advanced cancer. Individuals struggled with not only cancer, but life itself. Most had struggles early on in their lives, ranging from losing a mother or other trauma, including rape, domestic violence, wartime military service, or having family members murdered. In addition, they had concerns about housing, personal safety on dangerous streets and neighborhoods, transportation to appointments, limited money for medication co-payments, and healthcare systems that made them feel unwelcome. Lacking family support, as well as having drug and alcohol problems, were common in the urban poor. These participants reported feelings of behavior that were demeaning, insensitive, and dismissive from ancillary staff. In addition, individuals that were hospitalized reported feelings of frustration, being ignored, and neglect from nurses. Health insurance dictates what kind of medical care a patient receives, including cancer treatment. Individuals that perceive the lowest access to care are the uninsured or those with Medicaid. Not affording care was the most frequently reported reason for delaying medical care, tests, or treatments. Despite the Affordable Care Act of 2010 expanding insurance to millions of low-income individuals, more than 32 million people remained uninsured in the U.S. in 2015. Medicaid insurance payment rates to providers are also significantly lower than private insurance or Medicare. Women with private insurance in the U.S. had similar outcomes to any woman treated for cancer in Canada, regardless of their poverty level. In the U.S., women with private health insurance or Medicare were more likely to receive better care than those with Medicaid programs or uninsured. Women with Medicaid or uninsured were diagnosed later, waited longer for treatment, and had less access to treatment and were less likely to survive. Indigent patients were less likely than those with private insurance to undergo surgery for stage 1 through 2 non-small cell lung cancer, and less likely to undergo surgery or radiation-based therapy for stage 3. The risk of death was twice that of individuals with private insurance. Prostate cancer is the second leading cause of death in men in the United States. African American men are diagnosed with prostate cancer up to 65% more frequently than their Caucasian counterparts and twice as likely to die from it. Contributing factors are lack of early diagnosis and treatment in African American men. They express distrust of the medical system and perceived cancer as a death sentence. Rural dwellers are reported to have less access and utilization of early cancer detection programs. Other factors are lack of understanding of prostate symptoms and prostate screening, lack of a sense of a relationship with their medical provider, past family health practices, fear, and threat to manhood. Between 2008 and 2016, many community cancer clinics closed, leading to a negative impact on travel time for Medicare patients. Increased travel distance to cancer care is associated with more advanced disease and diagnosis, decreased use of recommended radiation, and higher mortality rates. Medicare spending was higher in cancer patients with longer travel times, possibly due to hospitalization rates. Patients were more likely to be hospitalized locally with lack of specialized oncology providers. Reasons for vulnerable patients going to local hospitals instead of commuting a longer distance to a cancer community network are difficulty with transportation, cost of travel, desire to be close to family or friends, or their overall health. Federally qualified health centers, or FQHCs, are funded by the Health Resources and Services Administration to provide preventive and primary health care services, including cancer screening, to the nation's most vulnerable populations. Even with these services in place, this population still uses emergency departments for primary care services. This may be due to lack of awareness of services for the uninsured. Ensuring these services are communicated to the underserved populations is critical in eliminating cancer disparities.